All right. So, what's up, world out there, all over the world, all across 7 continents? As you know, here today we have one of my favorite guests, if not the only guest, to be honest, William Bridge on the Psych Life podcast. How you doing,
Hey
William?
Juan, I'm doing well, man. How's everything on your end?
Oh, just doing great, man. Especially now that we got the podcast on Spotify. It took a little while, but now it's a lot more easily accessible for the audience. So I know that you're probably really glad about that, huh?
Yeah, that's exciting. I appreciate you working at that for quite some time. It'll be a good platform to kind of get a lot of these conversations out there.
Yeah, and William, today we're gonna change it up a little bit. We tend to go inside each topic with a specific structure, a specific topic, and today we're gonna make it a little bit more general, macro it a little bit. And I just want to talk about the mental health field in general. And one of the reasons I wanted to do this podcast today, William, with you was because I've heard a few psychology and mental health related podcasts, and they tend to talk a lot about, the way they can help an individual, which is great podcast material. But I never hear them talking about the actual field. And I think in our case, we have two clinicians here. You work in a hospital setting as a psychiatrist, and I work in an outpatient setting here in South Florida with my master's. And this is a perfect time for us to maybe teach the audience or make them aware of the mental health situation here in the country. So what do you say about that?
Yeah, man, I think it's a good idea. And we were talking a little bit about, just our own kind of challenges and changes we've seen in the kind of psychosocial realm of the care we provide. You only have a patient in front of you for so much time each day, but where things kind of become very intriguing are the limited resources that are available outside of the clinical encounter themselves. Before the podcast, before we were recording here, we were talking, it looks like, on my end in the Carolinas, very, very limited outpatient type of facilities, whether it's outpatient clinics, intensive outpatients that you were mentioned, I know they can go 5 to 7 hours per day. So the patients do everything pretty much but sleep there in intensive groups and that type of thing. However, in North Carolina, it's very few and far between. But seems like you were saying in Florida, there's you're having more of those in the inpatient beds when you have a critically ill patient that could probably have criteria to come inpatient. They're not necessarily available, and the patient ends up staying in the emergency room or jail or county jail, whatever the case may be.
So just to break it down for the audience, I appreciate that, William. When someone comes inside the office, they're assessed for the therapeutic services they're going to receive. And depending on their level of care that they need, they get referred or for outpatient services, which is one time a week. For adolescents, it's about 1 to 2 hours a week. Intensive outpatient services, which is 6 hours a week for adolescents or 9 hours a week for adults. And then there's the residential settings and settings higher. And that's the setting that William works with, guys. Okay. And William was just elaborating, and I appreciate that, William, how over there in North Carolina, there's not that much outpatient setting, right, William? And yeah.
Yeah, exactly. I mean, there's an adequate amount of there's certain amount of clinics where you just go. There's your 45-minute appointment, or your therapy. Here's your medicines, and I'd like to see you back in 4 to 6 weeks. Have clinics, but where we're lacking is the bridge from the hospital to clinics. So when maybe they're not sick enough to be in the hospital, but they're not progressing and being seen only 6 weeks in the clinic. So, they keep coming back, frequent readmissions to the hospital. We send them out, and it's just kind of to interrupt the pattern of readmission. So we don't have, the intensive outpatient is very few and far between. And I think another thing that is good to talk about is, you familiar with ACT team services? Have you said ACT? Have you heard of that?
Yes, yes. It's actually becoming really popular down here.
Yeah, so that's we do have that which can help, but and I guess just for the community out there, it's basically it's an established medium for almost like a mobile clinician team that can go to the patient's house. A social worker to make sure the transportation, the food, the living conditions are okay. You could have a nurse kind of organize the medications, make sure that the patient is monitoring, sodium intake, blood pressure, et cetera. And then you can have doctor or nurse practitioner to kind of make sure the medicines don't need adjusted. So it's almost, like a mobile team that can get into the house. And, it's really, really kind of helping a lot of the emergency rooms kind of, cut back on the psychiatric patients boarding in the ER beds.
Man, I'm so glad you brought that up, William. I promise you, I'm so glad you brought that up, because that's one of the topics I wanted to get into, and we probably want to touch on so many topics about the mental health field in such a short period of time. And when you just mentioned it, well, first you mentioned that there's not that much outpatient services over there in North Carolina. I think you told me the closest facility that provides intensive outpatient, once again, guys, intensive outpatient is about 3 times a week of counseling, 6 hours for adolescents or 9 hours for adults. You said that there's not one within 100 miles of your hospital or where you work and the setting where you work. And to me, that is crazy, because if someone leaves the hospital after being in there for a crisis, or they just meet the criteria for intensive outpatient and they can't get the services that they need, whether they're paying out of pocket or it's coming from one of the services of the community, a community service, then all of a sudden they are going to be checking themselves back into the hospital. That's number one. And that creates all of a sudden an influx of patients at the hospital. And once that you already know what's going on, but you may not be able to help the way that they need to be helped, because there's follow-ups required in this process. That's number one. Number two, when it comes to the ACT, which is a program where it was originally made for professionals to collaborate together on a case or on for the mental health benefit of an individual is probably better put. I have found that and this is where I'm glad we're having real conversations, William, where I have found down here in South Florida that is, people talk about it, people verbalize it, people say a bunch of stuff, they have meetings about it, but I haven't actually seen them actually practice it. So I'll give you an example. I get clients all the time that are referred by probation officers. I have a good relationship with the probation officers in the community. So I tend to get a lot of referrals, and I work close hand with the probation officers, but I never see the nurse after they were checked in, let's say checked out of the Baker, the citrus, which is they were Baker acted, they get checked out of that setting. I never see anybody come by. I never see other social workers come by. I never see the case manager. Sometimes the case manager takes days to answer the phone. And that is the type of stuff I'm seeing down here in South Florida. So have I'm sorry we're jumping around, but have you had a good experience with ACT?
So, so here's the thing. And you bring up a lot of good points. So this act, I guess, is probably defined. You're 100% right. Came out as like a collaborative care approach for multidisciplinary patient care. So I think it stands for assertive care team. or assertive community uh, team. There's a couple different acronyms for the same thing. So what, in my experience with it, Ron, is that if I'm discharging a patient that, in my opinion, um, comes to the hospital on a frequent basis because they're not getting to their outpatient appointments. And that could be, either medication non-adherence, lack of transportation, a negative experience at the outpatient clinic, whatever the case may be. um, that's who becomes on my radar for these ACT team services. So it's not, it's not to make it so everybody has in-home behavioral health care. I think it's important we kind of define that for the community. It's just those people that, have not been able to make use of the outpatient resources. So that being said, Ron, so I think that it cuts both ways. I've had conversations where, because of a complicated case, either the patient is pregnant, or the patient has a complex abuse history or family dynamic, that the psychiatrist that is the ACT team psychiatrist that oversees the team will want to speak with me, and I'll kind of present the patient why I think the ACT services are necessary. And I think that's very helpful. It seems like that's only a mandated thing when the case is complicated, but otherwise they're reading my notes and then they're picking up care, outpatients. Um, and it can be really helpful, but here's what I'll say is that the psychiatrist does not go to everybody's house every appointment. So what a lot of the things implement as well, these ACT teams, and this is yet another level of mental health services, is mobile crisis teams. So that's, let's say that the ACT team sees a patient on Thursday, but on Sunday, a situation escalates where the patient's either decompensated very quickly and they're having hallucinations, very paranoid or acutely suicidal. The ACT team can be contacted, but when the appointment's not there, they're kind of at the limits of the phone call. So they've implemented mobile crisis teams. That's yet another layer to kind of go gauge the situation and say, is this someone that needs to be involuntarily committed or brought to the emergency room? And that's where I see a breakdown in the system, because these mobile crisis teams have a very low threshold. I don't, honestly speaking, I don't know of the training that the staff has. But if there's anything that's like even remotely, they just involuntarily commit the patient, bring them to the emergency room. And I'm not sure exactly what we've avoided, because the same thing would have happened if the patient called 911. And usually these services, we're talking a little bit, SMI is, serious mental illnesses, is kind of like a common thing you hear. So this is the chronic schizophrenics, the very severe substance abuse plus, refractory depression. So very complicated, multi-layer, mental health disorders, so to speak. So
you even mentioned and I had that question ready, but you pretty much answered it. It breaks down, right? It
yeah,
sounds really good in theory, but sometimes that crisis team for whatever reason breaks down. And now we're gonna switch gears, if you don't mind, William, to my experience a little bit, where let's say I'm working with a client. I have a caseload, right, of about 8 to 10, typically fluctuates, even sometimes 8 to 12, depending on how many outpatients, intensive outpatients, et cetera, et cetera. And something happens over the weekend, and it's a crisis. Like, for example, not too long ago, I think about 3 weeks ago, I had someone call me on a Sunday night saying that that their son had taken LSD and he's vomiting and all these things. I got the voicemail. I didn't pick up the call at the time because I have a work phone, and when I came in on Monday, I found out that this is what it was. Um, there was I immediately called the person's JPO. I immediately called. I asked the mom what was the symptoms involved, if he was okay, where was he at, was he in a safe place, what was it that she did that night. But there wasn't, and there's a psychiatrist involved on his case as well. There's the probation officer and there's a social worker slash case manager. It's so everybody's so slow in responding to this crisis. It took about 48 hours before anybody else was able to intervene or be involved or get anybody to show up. And so it leaves individuals within the team almost isolated, in this case myself, because all of a sudden I had to make decisions for the client without the team, because the team can't respond so quick. And I'm wondering because my caseload's only between 8 and 12, but I'm wondering now if the other people's caseload, the other individuals that are part of the team, if their caseload is too big or whatever it is. Because in theory, it sounds good that everybody's going to work together towards the mental health benefit of the client, and respond when needed. But it doesn't really necessarily work that way, and that is somewhat troubling. William, you mentioned there's a lack of outpatient facilities where you're in your setting. I mean, you even mentioned that intensive outpatient, there's not one near you for 100 miles. But over here in South Florida, it's a little bit different. Um, it's a little bit different because we don't have any residential facilities. We
Mhm.
actually don't have many at all. I think for adolescents, we have two adolescent male facilities, adolescent males, guys. That means anyone below the age of 18, so 17 and under, and they have to be at least 12. And no female adolescent facilities, none. And I think we have two female adult residential facilities and maybe one adult male facilities. Now, these are the facilities I'm mentioning, guys, are are funded through a network, or DCF, you might know them as, but they're funded through a network where the services get provided for a small cost, a small fee. And this is somewhat troubling, William, because, for example, I have adolescent female clients who sometimes meet the criteria for residential treatment, and then all of a sudden, immediately, um, I noticed that there is no residential treatment for them. And so what happens is they expect the judge has no option, and they expect the clinician, in this case myself, to continue providing intensive outpatient despite the resistance, despite them needing a more structured setting, despite them not meeting the criteria for intensive outpatient. And you can see where therapists like myself and other therapists in the community become very scared and worried,
Mhm.
because you're causing a liability potential there. And that's one of the things that I get worried about. So I just find it a little unusual how over there in North Carolina you guys are struggling with a different issue than what we're struggling over here. Over there, it
Yeah.
seems you guys have beds available at the hospital, but sometimes people want to occupy those beds that don't really necessarily meet the criteria. Um, what do you do when someone comes inside the hospital and they want to stay there, or they're coming for services, but they shouldn't really be there? What ends up happening, and what are some of the concerns that come in your mind?
Um, yeah, so that's a good question. So, and I think I just want to clarify as well, one just for the audience, is that now when I say inpatient facility or inpatient hospital, that is, kind of an acute, we call them like almost like micro hospitalizations where, it's acute stabilization in the 5 to 7 day in the hospital type of length of hospital stay. So the residential, of course, is more of a semi-permanent until the patient can demonstrate stability on a longer term basis. So we really don't have too many residential uh, or intensive outpatient facilities either. It's just we have, comparatively speaking to other states, we have a lot of these inpatient hospital beds. Um, so, and just I wanted to touch on, I made a note here, what you were describing about, patients and, the team and the patient load being, maybe overwhelmed, or they were dealing with 5 of similar situations from different areas at the same time. So it took 2 days. Read this interesting fact that because of exactly what you're describing with everyone kind of being maxed, you weren't supposed to be answering your work phone on Sunday. Psychiatrist didn't get back until Tuesday. Social worker had somebody covering for them. You see this all the time. And because of this, what the families, friends, coworkers end up becoming desperate to the point where, what do? They call 911, because you're just kind of at your wit's end. You don't have that many more options. So it's estimated that nowadays, that if you take a police officer that's right out of the police academy in modern day times, it's they say that 20-25% of their duties, and this is everything all included, will be dedicated to mental health, either calls to the house, transportation from the house to the emergency room, staying in the emergency room until psychiatrist, ER attending, transportation from the hospital to the jail or to home because they were involuntary committed. So you can imagine you're a police officer that goes into the academy. You do not imagine that 1 out of every 4 things you do is mental health related. I mean, that just speaks to the massive shortage of resources that police officers are. A quarter of everything they do is dedicated to mental health, and they had no idea it was coming.
Do I know they have no idea what's coming, because I'm looking at them in the streets and they're wearing what looks like military equipment or bulletproof vests. Do they know that 25% of the calls they're gonna get are mental health and not just flat out shootouts? I mean, but
Yeah, that's what I think, and it speaks again, Juan, is that this is only just coming, right? So we're still even getting caught up with the numbers. So if you could imagine, there's nobody in there, the academy training, some can argue, is too abbreviated. And when it comes to the emotional dynamics of a high intensity type of domestic call, some of what the low thresholds for pulling a trigger can be attributed to lack of kind of psychological understanding of what's going on. Not sure if you've read some of the stats about the people that do get shot by police, whether it's justified, unjustified. More than half of them usually, I think it's, well, actually, let me correct myself, I think it's somewhere in the 40% have treated or untreated mental illness. So throughout their training, there's no mental health providers in the academy telling them, like, that's what this looks like, that's what paranoia looks like, that's what, to them, it's all bad. You know what
it,
I mean? So
and
it's a whole nother, I mean, we could do probably 10 podcasts on some of the experiences I've had, just even in the emergency room, like how they react to an acutely agitated patient. It can be very concerning.
William, this is something that I did a video on this. It didn't get much traction, but I put it on IG Live one time. This is about a year and a half ago or 2 years now, and that statistic you read is interesting, where the deaths that happen, so a lot of times, there, there's a lot of cases. I'm not saying they're important or not important. I'm just saying the ones they put on TV, or the ones they put on these big networks, these
Mm-hmm.
are just political cases.
Mm-hmm.
There's cases every day where someone gets shot, an incident occurs, someone gets hurt because the police officer, not the individual themselves, is the problem, but they didn't get enough training in the academy, as you were talking about, to deal with these issues, and they tend to approach every issue as if it's an authority problem, a defiance issue, right?
Mm-hmm.
They're a criminal, that's why they act like this, or whatever, and that's not true. So there's two factors here at minimum. I mean, life is variance, and there's many factors that we cannot even see. But one of them is they're not getting enough training. So what happens is when you don't have enough training, you don't have an understanding, and then also the trauma that they tend to experience on an everyday level. This is something that's not addressed often enough, but police officers always have to go into high intense crisis situations, and they don't realize it. And so that can create, if that call that they just had is not able to be processed, then what happens in the next call
Yeah.
and the next one after that? And all of a sudden what happens is that it could be termed as secondhand trauma, which, because they're constantly engaging with individuals that are struggling with the symptoms of trauma and they don't realize it, or themselves are being exposed so much that their brain's having trouble processing, and all of a sudden they're the ones experiencing the traumatic symptoms. So there's two factors there. Your experience though with the police officers, because this does involve mental health, William, and we're not talking about police officers. It's actually, I'm happy because I work with a good community of police officers here in South Florida, especially probation officers, because I actually care. But what's been your experience in these responses in the emergency room? Because in the emergency room, I would figure the police officer has an understanding that they're not the professional there. It's not about seeing if a license is fake or real. That's not what the job is being called at in the hospital. The professional is yourself and your team and the nurses. When you say their responses in the unit, what do you mean by that?
Well, I sympathize with a lot of what they do, and I think should make it clear that I couldn't do what they do every day, so I don't expect them to be able to do what we do every day. But you're right. There's kind of this almost subliminal or under the radar hypervigilance to every situation that they're going into, because it's a um, crime these days has been amplified. It's these home invasions and stuff. That thing, you don't hear much about that anymore. It's like the mass shootings and everything. I think that's closer to the surface, and the access to firearms illegally is just astounding these days. So they're going into these calls, and it's not like it was 15 years ago. So I can see a lot of what comes from them, and I think the interesting flip side is it as I see them as patients as well, right? So I can see the patients that have been affected by some of the scenarios, and you can imagine one is if you have a mental illness and you're in and out of what we would perceive as like a reality assessment of a situation. Those times when it seems that you're clearly thinking, even if it's 10 or 12-minute stretch, um, and then there's times where all of a sudden you kind of backslide and you're not perceiving reality. If you see authority figure police officer that is trying to, either get you in cuffs, or, I mean, you've already had a preconceived delusion that you have got to get out of this situation, right? So it's not even you making the decisions about running. It's, it's kind of your symptoms making those decisions. And that's what I tell a lot of the officers. But I think that what I see in the emergency room, to answer your question, is some of what becomes uncomfortable is that there's an intimidation factor. So there's kind of the goal is to verbally redirect the patient without like using, any force. So these, therapeutic holds or restraints or chemical restraints, physical restraints. But when, you have like 3 or 4 hospital security and 2 or 3 police officers show up to a patient that is yelling, I very rarely does that help,
Mm,
especially when it's not behavioral, it's psychotic, or so I've seen situations where it goes south because of that. But I think that the awareness is getting out there, similar to what they've had in the past, where they call them, the short name is drug courts, where somebody that's just been kind of fallen victim to the pattern of recurrent drug use and end up in courts, as opposed to going through the main track courts where things could take years. There's now mental health courts that are being established, and I think this will help kind of separate, what a criminal is and what a patient that is decompensated from a mental health standpoint, and the tracks of sentencing, so to speak, will be entirely different. So I think that'll help.
you just mentioned drug court and how I'm now currently not in my case, but I've had many cases in drug court, and it has
Mhm.
been beneficial. And you know, William, I'm so glad you touched on it, because with the police officers, when they show up to a hospital room and there's 2 or 3 of them with like 3 security guards, and you said that very rarely helps. And even I would be horrified. I would be
Yeah.
horrified if whatever I'm going through, that's the response I'm getting. It's almost gonna make me go 0 to 100. But just I know we've gone a little bit, William, but just 10 more minutes, because I do want to touch. There's 2 things. So one, I want to tell you a story that you're going to be in shock by, and I didn't expect the podcast to go this way today, but I'm glad it did, because I think there's a lot of good information for the audience. I recently had a case where the kid was they found these little marijuana cartridges. I know we've talked about them in the past in our other podcasts, right? They found
Sure.
like 2 or 3 of them. The parents, I guess they didn't know what to do, and the very next day in the morning, they went to the school to show the principal what these marijuana cartridges, to show them, hey, like, this is what my son's been doing at your school. Almost
Yeah.
there's in that situation, the person always wants to put the blame somewhere,
Hmm.
and so this is what's been happening at your school. And the principal, this is the one that you're going to get a kick out of, they recommended, and I told the parents that I was not on board with this, that I did not want this to happen, that this was not good for the kid, that this is not the type of response that we should be having. The principal recommended that to send the school police officer, the cop, right,
Hmm.
to put the kid in handcuffs at his house, but it was a scare tactic. They weren't going to do anything,
Yeah.
right? So are you checking this out for a minute?
Yeah.
And the kid, when I had the session, because I had the session 48 hours after this incident, he told me that, oh, I knew nothing was going to happen, because this has happened before with some other kids at the school. Nothing ever happens. And I was just in shock that they would even use this tactic. So it just goes, this story isn't to put down the police officer. The police officer is doing what he's trained to do. It's that the system hasn't caught up with the mental health field, and that's something that mental health awareness needs to grow a lot. And the way we go about incidents involving mental health, whether it be substance use or just mental health and schizo, it really needs to change, because it's not an authoritarian issue. It's something much deeper. Now, the last thing I wanted to touch on, William, and we'll call it for the podcast because I think this has been a good one, is what happens when the mental health field becomes monetized, and that is something I'm experiencing here. That's, you go to school, you get your degree, you start working in the field through your internship, and then you get a job, and you start seeing that the stuff you learned in school is great and everything, but it's not necessarily the real world. And what I mean by that is that I'm seeing the mental health field worry more about money sometimes than I see them worrying about the actual patient care, client care. And one example I'll give you is the residential facilities. And I know you already broke down that term. When you say residential, you're talking about inpatient beds at the hospital 5 to 7 days. I'm talking about months, a place
Mhm.
where they stay for months until they can reach sobriety and a level where when they leave, they can have the skills to remain sober. Um, I'm seeing that it's about how many clients you have in there. It's always about how big, how many service events are you turning in, how many hours of clinical service are you providing, therapeutic service are you providing. The conversations are always focused about goals that you have to meet that don't involve the client themselves, goals for the agency or the community mental health center or for the people or the funders of this. It's always goals. It's never about the actual patient care. And what happens is and I'm finding is that they're putting out these crazy quotas, and in turn these crazy quotas make people to a certain extent almost have to be not lie but be somewhat deceptive in the way they're putting out the information. Now I have to be careful with my word choice because but I that's the thing. This is mental health awareness, and it makes it hard for clinicians like myself because you have to now all of a sudden provide excellent patient care, which is what I find more important than anything. It's more fundamental than anything for me. And then you have to also meet these crazy quotas. And, they're crazy as in 27 hours of client contact hours a week. That doesn't sound too crazy, but when you include that some of those you have to do a little bit of a drive, sometimes you're going to end up going over 40 hours, 50 hours. And so I just want to see what you think about that, how the mental health field, it was made to help individuals go through their issues and their substance abuse and mental health issues, but sometimes we're finding that the field is being monetized. And I just want to hear what you have to say about that because you've been working in the field for a while, and I'm gonna be honest, William, you're a really good clinician that knows your stuff, man.
Oh, thanks, man. I appreciate it. So the so what I'll say about it is, you know, any resource in medicine, whether it's substance abuse counseling or inpatient, electroconvulsive therapy. I mean, it doesn't matter the level of treatment. It's got to be able, because we do not have a social healthcare system here. It's got to be profitable, otherwise that resource will go away and will be kind of compounding an already bad problem. So I think that needs to be said. But on my end of it, I do see it being an issue. Usually, what I get is I'll have somebody. Let's say they come into the hospital on Saturday. I take over for my counterpart on Monday. By Tuesday, depending on how the notes were done, if they're in the hospital, you need to make sure that you document why every day they're in the hospital, right? Because it can't just be they're here, this is what we're doing for them. You need to always, every day, I have to prove myself and my documentation why they're there. So if I start saying suicidality has gone from active to passive, meaning when they came in, they were actively thinking about a plan, but now it's more passive, and they're now thinking, I wonder what it would be like not to be here. Um, if I say that, then that means they don't need to be in the hospital for that, right? So you got to be very careful. You know, hallucinations may become where they're no longer affecting sleep, or paranoia gets reduced to the point where the patient's able to function appropriately. Anytime they get better, you're having to say, well, then why are they still there? Right? So the system kind of forgets about all of the outpatient side to keep them well. You need days to make sure the pharmacy had at their closest pharmacy has their medicines, that they can get to that outpatient follow-up appointment to set up the ACT services. So I mean, I think the common theme of what you and I are saying today is that there's all these points on the map, right? So there's the patient's home, there's the inpatient hospital, there's the ER, there's the outpatient clinic. There's all of these the kind of bullet points on the map, but it's the roads in between each of those that's the problem is, right? So, you know, that's where the police come in, because without them, you know, I don't know where we would be, because, you know, all the mobile crisis and the ACT teams, we see that they're good to a point, but then once you cross the point of, you know, desperation, 911 is the only thing we can do. So, you know, the monetary side of it is a necessary evil. But, you know, I think that a lot of the healthcare dollars for any given state, we're 20 years behind on what is needed for, you know, mental health. You know, from the point in the 80s where these community mental health clinics were shut down, I think we've been trying to catch up ever since.
Yeah, and I agree. As of now, it's a necessary evil, because if the quotas aren't met, or whatever you want to call it, I mean, then we won't have any services to be able to provide. So you're right about that, and I think, William, I think we'll call it on this one. I think this was a good podcast today. It was a little different than what we typically done, but I think now, after all these podcasts, we have a good sample size, and we're experimenting on what works and what not. And this was actually a pretty good podcast, because we touched on different elements within the mental health field. And most, just like all our other podcasts, is we need to have a part two to this, because we could keep going for a long time. And we didn't even, and I mean, we just touched the surface. We didn't really dive deep, like you just mentioned at the end. But I don't want to open Pandora's box on that one yet. We're going to save that for another time. And I'm going to definitely jot it down on my notes. And thank you, audience out there, for listening. And I appreciate your support during the last year. And William, thank you, bro, for being part of this podcast. All right, man. And for coming on here today so early in the morning. I know you're used to this, waking up at this time. And I'm used to it too, but I normally are used to it to go to the gym. But it's always nice to start the day off like this, because it's almost like a refresher of everything. And thank you, man, so much. All right.
Well, thank you. I appreciate it, man.
All right, guys. Take care. Till next time, and see you later, William.
All right, we'll see you on.